afternoon, everyone. Thank you for inviting me today to be a speaker in this great conference. So I'd be talking about treatment of ANCA-associated vasculitis. Where are we now? Okay. Those are my objectives. And to start with, ANCA-associated vasculitis is a group of systemic diseases affecting small vessels that will lead to damage to several organs and tissues in the body. You all know that we have three main types: granulomatosis with cholangitis, microscopic cholangitis, and eosinophilic granulomatosis with cholangitis. Other forms are renal-limited vasculitis and drug-induced ANCA vasculitis. The disease is characterized by ANCA-specific for zygomoproteins present in the cytoplasm of neutrophils, namely myeloperoxidase and proteinase 3. And the most serious complication is pulmonary hemorrhage, renal failure, and infection, and all of those manifestations could be lethal. A little about epidemiology. The incidence and prevalence are hampered by the rarity of the disease. However, we are seeing an increase in cases of ANCA-associated vasculitis nowadays, and that's because of many factors, including climate changes, as well as improved classification criteria and improved testing of ANCAs, as well as increased awareness of the disease. And it peaks in between 60 to 79 years of age with a higher incidence in elderly, and that's partly because of increase in testing of ANCAs as well. It is slightly more common in women. However, this is not confirmed yet by studies. And the latest classification criteria is the 2022 ACR-Euler classification criteria for the three main types. An alternative diagnosis should be excluded prior to applying the criteria. And each criteria includes clinical and workup points. The summation of scores indicate the classification of the disease. Going to the pathogenesis, it's very complex. And the presence of genetic susceptibility and environmental factors, ANCA have the central role in the pathogenesis of the disease because they induce excessive activation of neutrophils. This results in injury to small blood vessels. Other immune cells, such as B and T cells, as well as complement system and humoral factors, are also involved in the pathogenesis of ANCA-associated vasculitis, and that will lead to inflammation and increase in permeability of vessel wall and hence tissue injury. Understanding the pathophysiology is very important to understand why do we treat our patients with the medications that we have right now. Clinical presentation is heterogeneous, and it depends on ANCA vasculitis type. For example, GPA, mainly, we see upper and lower respiratory tract involvement. In MPA, it preferentially affects the kidneys. And in EGPA, it initially starts like an allergy, including asthma, and then it evolves into definitive vasculitis. Clinical picture and severity of the disease is associated with the number of affected vessels, the target organs, and disease activity. Clinically, patients may present with constitutional symptoms, upper and lower respiratory symptoms, eye manifestations, kidney manifestations. The most important one is pauci-immune necrotizing glomerulonephritis that can progress to end-stage renal disease. And aside from infection, the most common comorbid condition is cardiovascular system involvement, which is an evolving entity that is caused by acceleration of atherosclerosis. The disease activity can be measured by three main scoring systems. The first is Birmingham Vasculitis Activity Score, which is the most commonly used even in studies. And the second is the five-factor score, FFS, which is used to predict the 5-year survival. And the third, the Vasculitis Damage Index, or the VDI, which is useful to distinguish chronic vasculitis-induced damage. Now, what are the current advances in the treatment of ANCA vasculitis? Moving to the first and most famous medication, rituximab. So it is a chimeric murine monoclonal antibody that we all currently use because it is critical for ANCA-associated vasculitis treatment. And research found that it eliminates the CD20 expressing B lymphocytes through three main mechanisms. The first is antibody-dependent cellular cytotoxicity, the second is complement-dependent cytotoxicity, and the third is induction of apoptosis. And here's the timeline of the studies used in rituximab. So Rituximab in inducing remission was studied in many trials, and 2 randomized controlled trials evaluated the efficacy of rituximab for induction in GPA and MPA, namely the RAVE and RITOX-VAS. In RAVE, they included patients with new and relapsing disease without severe renal impairment, whereas in RITOX-VAS, they included patients with new onset disease and severe renal failure, including those on dialysis. RITOX was compared to cyclophosphamide in both studies. The RAVE and RITOX-VAS concluded that rituximab was not inferior to cyclophosphamide for the induction of remission. In addition, rituximab and cyclophosphamide had comparable mortality rates, and based on this, current guidelines recommended the use of rituximab as the first-line treatment for MPA and GPA, and in relapsing disease, refractory disease, and in those with contraindications to cyclophosphamide. Several other studies examined the rituximab use in maintaining remission, most importantly MAINRITZEN, MAINRITZEN-2, and MAINRITZEN-3, and they're all famous. In MAINRITZEN-1, it showed that rituximab was better than azathioprine in maintaining remission. It maintained its superiority at 5 years follow-up. In MAINRITZEN-2, a fixed rituximab dose was comparable to a tailored dose. It concluded that there is a slight but insignificant decrease in the relapse rate in compared to the fixed group of rituximab. Whereas in MAINRITZEN-3, they compared patients on rituximab fixed dose with those on placebo for 2 years, and there was a significant increase in disease flares in the placebo group, and all of those patients received an induction therapy prior to that, of course. Moving to eGPA, the results from 2 systematic reviews confirmed the validity of results obtained from observational studies. And the response rate in patients receiving rituximab in eGPA was similar to those with MPA and GPA by the European Collaborative Study. Most patients on rituximab had no significant, most patients with eGPA on rituximab had no significant effect on steroid sparing if asthma is present, suggesting a more of an allergy predominant disease. And the results from RIOVAS trial regarding the use of rituximab in eGPA, it has a conflicting results which raise the doubts about the real efficacy of rituximab even if ANCA positive with eGPA, and that's what Prof. Alberci was talking about. In 2021 ACR and 2022 Euler guidelines, they recommended considering rituximab for induction of severe new onset or relapsing eGPA, especially if ANCA positive with acute glomerulonephritis or high risk of cyclophosphamide toxicity. Another currently approved medication is avocapan. Avocapan is a complement 5A receptor antagonist, and Prof. Alberci also talked about it comprehensively, so I'm not going to talk a lot. C5a receptors are expressed on myeloid cells such as granulocytes, macrophages, dendritic cells, and mast cells, in addition to various non-myeloid cells. And if it is activated, inflammation and degranulation of those cells can cause a cascade of inflammatory reaction, leading to a vascular permeability and tissue damage. It works by blocking the upregulation of complement 5A on neutrophils by inhibiting their activation and chemotaxis. And avocapan went through the proper phases of studies, phase 1, CLEAR, and classic phase 2 trials, as well as the famous ADVOCATE phase 3 trial that Professor Alberci talked about extensively. So in conclusion, patients receiving avocapan had a significant rapid decrease in steroid dose. So other medications targeting complements, including eculizumab, which is a monoclonal antibody targeting complement protein C5, and it has not yet been approved for the treatment of ANCA vasculitis. However, it has been effective in refractory cases with aggressive form of the disease. Other agents blocking complement systems, including IFX1, which is in phase 2 trial, and the plasma C1 protease inhibitor, which is currently a treatment of hereditary angioedema. The third medication that I'm going to talk about is mepolizumab, which blocks the function of eosinophils in eGPA. As we all know, interleukin-5 is a very important cytokine for growth and differentiation of eosinophils, and it plays a very important role in EGPA. Mepolizumab is a humanized monoclonal antibody specifically targeting the alpha subunit of interleukin-5. And the pivotal study which led to the approval of mepolizumab in EGPA is the MIRA study. And subsequently, many other studies confirmed the efficacy even at a lower dose of mepolizumab. And in MIRA study, they recruited patients with relapsed and refractory EGPA, and they were randomized to either mepolizumab every 4 weeks or placebo, in addition to steroid and immunosuppressive medications. And it was observed that 50% of patients receiving mepolizumab had lower recurrence rate, and they had a significant reduction in the dose of steroid. However, the study has its own weaknesses. The first, they included only mild disease, and the second is that patients with the presence of ANCA in the serum were minority, so we couldn't generalize this study on all patients with GPA. Other anti-interleukin-5 currently approved for asthma and are under study in EGPA is rusiluzumab, which is a monoclonal antibody specific for interleukin-5 alpha chain, which has a promising results in reducing steroid dose, and benralizumab, which is a monoclonal antibody against interleukin-5 receptor, which has an efficacy in treating EGPA in another pilot study. And there is the Mandara study, which aims to compare benralizumab with mepolizumab in relapsed or refractory EGPA, and this study is ongoing. Mandara study is interesting because it's the first study to compare head-to-head two biologics for the treatment of EGPA. Moving to plasma exchange. The aim is to find a safer treatment for ANCA vasculitis and reduce the use of B-cell depleting therapy and cytotoxic medications. And PLEX is capable of removing significant amounts of circulating ANCAs. It was reserved for patients with severe forms of rapidly progressive glomerulonephritis and pulmonary hemorrhage. PEXIVAS trial included all comers with a GFR of less than 50, and thus aimed to answer the question of whether PLEX is an option for patients with kidney function impairment or not. PEXIVAS revealed that after a follow-up of 3 years, routine PLEX did not provide an additional benefit to reduce the risk of end-stage kidney disease or death. However, there are weaknesses of the study as well, which limits its generalizability. The first is that only 29% of patients had severe kidney injury, and by applying the Kaplan-Meier curve for their composite outcome, it suggested that there could be an early benefit of using PLEX. The second weakness is that 10% of patients in PLEX arm did not receive the prescribed number of treatment, and 4% did not receive any treatment of PLEX. The third is the lack of presented kidney biopsy data, and the fourth is that 27% of patients had some degree of lung hemorrhage. 32% of them had severe pulmonary hemorrhage. So again, the generalizability of the study we couldn't generalize it. That's why because of the weaknesses of the study and because we like to use PLEX, an updated systematic review was conducting and aiming to examine the mortality, end-stage kidney disease, and infection after using PLEX. So PLEX had a little or no effect on all-cause mortality at 12 months, whereas for end-stage kidney disease, PLEX probably had reduced the risk of end-stage kidney disease at 12 months and may affect longer-term risk. And for serious infections, PLEX increased the risk of serious infections at 12 months and may increase the risk of at a longer term. Moving to the international recommendations, and I mean by international organizations like BSR, YOLR 2022, ACR 2021, and KDIGO 2021. So all recommended the rituximab for induction treatment in addition to steroid. Most recommended its use as the primary medication in maintenance of treatment and relapse. It also was recommended if the disease was refractory to cyclophosphamide. And there is no difference in between the weekly dose for 4 weeks of rituximab and the 0 and 14 days. Cyclophosphamide is recommended for the induction by all organizations. However, ACR recommended it only if rituximab is to be avoided and in active severe ANCA-associated vasculitis. KDIGO suggested its use as an initial induction over rituximab in severe renal impairment and suggest combining rituximab and cyclophosphamide, especially for those who present with a creatinine level less than 354 millimole per liter. And all recommended its use in severe relapse over rituximab and in refractory disease. Moving to steroid, steroid is recommended by all organizations to be used in induction, in maintenance with a tapering dose, and of course in relapsing disease. BSR and KDIGO suggested the use of high dose for induction and relapse, whereas in Yoller and ACR, they recommended the reduced Pixivas dose, except in severe life-threatening disease. Methotrexate up to 25 milligrams per week was also recommended for induction and maintenance in non-life-threatening, non-severe disease. It is not recommended for refractory or relapsing disease, and it's to be avoided in patients with renal impairment. ACR only recommended the use of azathioprine with a steroid over cyclophosphamide or rituximab in induction of active and severe and non-severe disease. All recommended it for the maintenance in non-life-threatening and non-severe disease, except KDIGO, that recommended the use of rituximab over Imuran, even if it's not severe. And they only recommended it if rituximab is to be avoided. It's not recommended for relapse or refractory cases, and the dose is up to 2 milligrams per kg a day. For mycophenolate mofetil, it can be used for induction with a steroid in non-life-threatening and non-severe disease. Yoller and KDIGO recommended its use for maintenance. However, BSR and ACR recommended its use for maintenance only if methotrexate, azathioprine, or rituximab cannot be used. And the last medication is mepolizumab subcutaneously every 4 weeks. There is no mention of it in BSR or KDIGO. However, Yoller and ACR recommended it to be used for induction with a steroid in less severe, non-life-threatening disease. It also can be used in relapsing and refractory disease. Moving to the duration of treatment, so the recent 2022 Yoller recommendations recommended that the therapy should be maintained for GPA and MPA for 2 to 4 years. And that should be followed, and we should follow the patients for relapses. A longer duration of therapy should be considered if the patient is relapsing or have a higher risk of relapse. And so in summary, for a new onset severe disease, we can use rituximab or cyclophosphamide plus a steroid in GPA and MPA, mepolizumab plus a steroid in EGPA, or avocapan and rituximab or cyclophosphamide in MPA or GPA. For relapsing disease, we can use rituximab or cyclophosphamide plus a steroid for MPA and GPA, and mepolizumab plus a steroid in EGPA. For rapidly progressive or severe disease, we can combine rituximab, cyclophosphamide, and corticosteroid and see if the patient is a candidate for PLEX or not. If the patient achieved remission, we can maintain with rituximab in MPA and GPA or azathioprine. If not, we can use, again, rituximab or cyclophosphamide according to what medication the patient received first. So my take-home message: several forms of ANCA vasculitis make such vasculitis a very complex disease. The main target of therapy is inhibition of ANCA production, as they play a pathogenic role. Rituximab is effective in both remission and maintenance, with far fewer side effects than cyclophosphamide. And the discovery of the role of the complement pathway in MPA and GPA has made avocapan available in the treatment. Mepolizumab was the first drug specifically approved for EGPA due to its inhibitory effects on eosinophils. And until a better therapy is available, PLEX should be considered as an initial therapy for carefully selected patients with ANCA vasculitis, including those with severe acute inflammatory kidney disease. And there are a lot of emerging therapies in many phases of trials, and here I conclude my talk. Thank you very much.